I'll go for this.
Hello. Hello, Shyam. Can you hear me?
ആദ്യത്തെ ക്ലിക്ക് അടിച്ചു അവിടെ അല്ലല്ല അവിടെ ഓപ്ഷൻസ് ഉണ്ടല്ലോ ക്ലോസ് ചെയ്യാം ക്ലോസ് ഞാനത് റൈറ്റ് മൂവ് ത്രീ ബോട്ട് ബട്ടൺ അതിനകത്ത് നിന്ന് റീനെയിം അലൗ ടു മൾട്ടിപ്പിൾ ഇങ്ങോട്ടല്ലേ Good afternoon, everyone, and welcome to the second day of our scientific session. Now we have 11 papers actually totally scheduled in this particular session. We have from the delegates, okay, then we have most of them undergraduates, and there's one paper, one delegate PD paper, which is actually scheduled yesterday but could not be presented today. Now let me invite our judge for this first session, Dr. Vinesh Uday Kumar. He'll be assessing the papers in the first session, the delegate session, and he's the reader in Department of Oral and Maxillofacial Surgery, Pushpiri College of Dental Sciences. And who's the presenter who's ready today? I can see a UG presenter, Aditya. Sarah Paul. Sarah, are you ready with your presentation?
Sir, the first presenter is Dr. Anupama. I think she has not yet joined. We'll move on to the third presenter, Dr. Pooja, OMFS Delegate 03. Judge, please note the first presenter, Dr. Pooja, OMFS delegate 03. Dr. Pooja, are you there? Dr. Pooja? Dr. Pooja? Okay. We'll move on to the next presenter, Dr. K. Ramesh. Just please note, presenter Dr. K. Ramesh, OM office delegate 02. Doctor, are you there?
Yeah, good afternoon. I'm ready, madam, here.
You may share your screen, please. Put it on slideshow.
Yeah, I'm ready.
You may start.
Shall I start now?
Yes.
Yeah, good afternoon, all. Yeah, madam, shall I start?
You may start, sir.
Yeah. So, good afternoon, all. So, most of the cases, odontogenic keratocyst. So, most of the treatment modalities are peripheral osteotomy followed by curettage and peripheral cornea solution applications. So to prevent any recurrence of OKC, so we are following the standard protocol. So after that also we are having so many recurrence cases, and after using cornea solution having so many advantages as well as disadvantages because of chloroform. So it may damage the vital organs surrounding any. So that in our department, we conducted very small comparison study, 5-fluorouracil versus cornea solution, modified cornea solution. So in this presentation, I'm dealing with the advantage of 5-fluorouracil above the cornea solutions. In cornea solution, we can't use in any vital organs. The depth of penetration will be damage the vital organs also. So that for the purpose of any cyst involving any vital surrounding any vital structures, so we are using this 5-fluorouracil. So OKC, as you all know, that OKC is having highest recurrence rate among all other benign cysts. So because of satellitic cyst or darter cyst, or because of all other consideration, so incomplete removal of the cystic lining, or thin or feeble nature of the epithelial lining, or budding in basal layer of epithelium, bony tissues, or superficial epithelial or subepithelial space of epithelial lining, or parakeratization of the surface layer, or remnants of dental lamina can develop neocases, and growth of neocases from satellitic or darter cells. So because of this reason, the aggressive nature of the OKC, so instead of for cyst enucleation, we are doing curettage followed by peripheral osteotomy, and so we are doing chemical cartridging by using cornea solution in standard protocol. So we can manage conservative like enucleation. So we can have the recurrence rate in conservative treatment is highest recurrence rate in conservative management, and enucleation with curettage or enucleation with peripheral osteotomy, or including cornea solution applications also we are seeing recurrence rate. So in cryotherapy, there is chances of bony damage or fractures. So in marsupialization, you can't do in OKC cases, but because of recurrences. So resection and resection. So those things are we can avoid by using by using other adjunctive therapies like either carnage solution or 5-fluorouracil. So in carnage solution, so because of chloroform, so many disadvantages are there. So we can modify the carnage solution without chloroform. We can use this. So what is 5-fluorouracil? So it is an antimetabolite that targets the proliferating cells, and topical application of 5-fluorouracil after wound cavity immediately after curettage, and we have to keep this 5-fluorouracil at least 24 hours post-operatively. The effectiveness is eliminating the remnant of keratocystic layers and satellitic cysts, which are which are the cause for recurrence. The mode of action of 5% topical 5-fluorouracil over the modified carnage solution or liquid nitrogen, which can cause damage and which can cause the non-selective tissue necrosis. The pharmacological effect of 5-fluorouracil is affected by 3 enzymes. One is PS, thymidylate synthase, or TP, or DPD. The main mode of action is it inhibits and it damages the lethal DNA. It can damage the DNA structures, and we can reduce the recurrence also. And in our department, we carried out a very short study. So to compare the advantage of 5-fluorouracil in any vital structures like any mandible, in case we were doing very close to the inferior alveolar canal or very close to the orbital structures or nasal structures. So we tried by using 5-fluorouracil in those conditions, and we have got very good response and good results. So compare with carnage solutions. So we got a very less recurrence rate. We can see very less recurrence rate by applying 5-fluorouracil. So in carnage solutions, so because of one patient, we got recurrence because the patient is not willing for extraction of affected teeth. So maybe because of retrograde infection, or maybe because of remnants left over the root surface, there may be. So in 5-fluorouracil, we observed 22 months, and for carnage solution 27 months. So we got one recurrence case in carnage solution application, and this is the case. So FNAC was done and incisional biopsy was done, and we took all cases once they are proven histopathologically OKC only. So we included in our criteria the cases which we included in our criteria, they are proven biopsy. So histopathologically OKC cases only we included. And so intraoperatively after aggressive curettage, after peripheral architectomy, so we applied 5-fluorouracil intraoperatively, and we closed the wound, and we kept 24 hours and left. After 24 hours, we removed the gauze. And in case any the lesion surrounding any vital organs like inferior alveolar canal, so there may be chances of paresthesia. So we avoided by using this 5-fluorouracil. So we can appreciate how the cyst is managed by using 5-fluorouracil. So we can appreciate the bony formation in after 3 months also. So very good bone formation occurs here. So by this presentation, I can conclude that so many treatment modalities are there for any cystic uric lesion or OKC stage. So OKC is aggressive in nature. To prevent any reoccurrence, so we are using a standard protocol like carnage solution, chemical cartridgeation. But nowadays, so many articles are suggesting that we can use 5-fluorouracil. So we also took this as a short study, and we conducted very less amount of cases only, but we find very good result in applying 5-fluorouracil as a adjuvant therapy to prevent any recurrence of the OKCs. So So these are my so any standard cases. So we have to use the large amount of cases to conclude 5 very less cases. So we are so we can use as a alternative to solution in any vital structure area. Yeah. So this was my presentation. You can ask me.
Thank you, Dr. Ramesh, for the presentation. Now we move on to the next presentation. Over to Aditya.
Thank you, Dr. Ramesh.
Yeah, thank you, madam.
The next presenter, Dr. Sarah Paul. Judge, please note, Dr. Sarah Paul, Autonomous Delegate 04. Dr. Sarah Paul,
Yes, yes.
are you there?
Yes. Can I share the screen?
Yeah.
Dr. Ramesh, kindly stop sharing the screen. Dr. Ramesh, kindly stop sharing the screen. Dr. Ramesh. Thank you. Sarah, please share your screen.
Dr. Sarah Paul, can you please share your screen?
Just a second. Can you see my screen?
We can.
Start, sir.
We can see your screen, but not. Please share the screen. It's not it. You have a network problem there?
No, sir. Can you see my screen?
Yeah, now we can see.
Please
Now put it on slideshow, please.
Yes, I have put it on. I have already
Yeah,
put it in.
perfect.
Okay. Can I start, sir?
Please.
Okay. Good afternoon, everyone. So I think I am visible and audible. So I am presenting on OKC, surgeon's dilemma. So autonomous keratosis is a benign cystic lesion of the jaw, known for its aggressive nature and propensity to recur. And there is a controversy existing among the oral and maxillofacial surgeons regarding the treatment protocol of OKC. And one surgeon's aggressiveness may be another surgeon's conservative. Now, what is the background of my study? I have referred these articles, which says that recurrence rate of OKC is about 58.3%, and about 20% of the recurring lesions occurred between 5 to 10 years postoperatively. And a periodic follow study the OKC for a long-term follow-up with evaluation of the efficacy of our center treatment protocol with reference to the recurrence rate, and to conduct the epidemiological investigations on the pattern of OKC, and to analyze the recurrence rate in same patient for a follow-up. Now, our protocol was that we used the treatment of cystenucleation combined with curettage and adjuvant therapies like peripheral osteotomy and chemical cauterization using Carnoy solution. This is a case of 30-year-old male patient with a OKC, histologically confirmed case of OKC in the mandible posterior region. Methodology: I have done a retrospective analysis of 30 patients who were histopathologically confirmed cases of OKC with who were treated with specified treatment protocol from the year 2002 with a follow-up of maximum 12 years and minimum 3 years using the medical records and radiographic images, and all cases were followed up using OPG. Inclusion criteria includes all cases which are treated with a specified protocol, which is histopathologically confirmed cases whose patient records are available with a 3-year minimum follow-up, and even all cases initially treated elsewhere were also included. Exclusion criteria: less than 3-year follow-up or patients treated elsewhere with no surgical treatment records, patient records, radiographic cytologic reports, or patients who were lost due to follow-up were excluded from the study. And my inferences were that the age distribution, the maximum peak of incidence of OKC was found in the range of 21 to 30 years, and the next one was within the range of 51 to 60 years. And this is in confirmation with the literature. And also in regard to the sex distribution, male predominance was found compared to the female. And the site of distribution, mandible more common than maxilla. The mandibular posterior were more common than the maxillary anterior region. This was in contradiction to the literature which suggests that the maxillary anterior is more common than the maxillary posterior. Now, clinical presentation of most of the cases were that they reported with either pain or swelling, or the second most clinical presentation was discharge. Radiographic appearance: multilocular lesions were more common than the unilocular lesions. Syndromic association, only 3.3% is only syndromic in our report. Histological appearance: parakeratinized were more common than the orthokeratinized. This supports the literature that orthokeratinized cases have a lesser tendency or lesser proliferative activity compared to the parakeratinized. This is a review case of a 30-year-old male patient with cases of the lower mandible posterior region, which is followed up for the first 5 years every year, and then every 2 years for the next 5 years. About 13-year post-op OPG shows a sufficient amount of bone formation. Another case of 50-year-old male with a mandibular posterior region extensively involved with OKC, follow-up for about 11 years, shows a well healed area. So I would like to conclude that none of the patients showed any recurrence throughout the period of follow-up, which might be indicative that the presented protocol of enucleation, curettage, chemical cauterization, and peripheral osteotomy is an effective option to treat OKC. These are my references. Thank you.
Thank you, Dr. Sarah Paul. Just please note that was Honorable Delegate 04. We'll move on to the next presenter. Next presenter is Dr. Pooja Chandrasekhar. Just please note, Dr. Pooja, Honorable Delegate 03. Dr. Pooja, are you ready? Dr. Pooja?
Please unmute yourself, Dr. Pooja.
Good afternoon. Am I audible?
You are audible.
Dr. Pooja, can you please share your screen?
Am I visible and audible?
Yeah, you are. Can you
Good
please
afternoon.
translation?
Yes. Good afternoon. I am here with my presentation on OSMF. As we know, OSMF is a pre-malignant condition of oral cavity. It was Sushruta who described oral submucous fibrosis as long back as 600 BC, and it was Joshi who coined this word oral submucous fibrosis. And we already are aware of the etiological factors of oral submucous fibrosis. It might be tobacco chewing, areca nut, and smoking, chilies, nutritional deficiency, and immunological disorders. And I am here with my presentation on the comparative study on the efficacy of intralesional peripheral blood-derived mesenchymal stem cell therapy and intralesional drug therapy for oral submucous fibrosis. It is a randomized controlled trial. And it was Pindrop who defined this word oral submucous fibrosis as an insidious chronic disease that affects any part of the oral cavity and sometimes pharynx, although occasionally preceded by or associated with vesicle formation. It is always associated with juxtaepithelial inflammatory reaction. And we are very well aware of the definition, and we are aware of the symptoms and signs as well. It might be reduction in mouth opening, burning sensation, hypersalivation, difficulty in speech and swallowing and mastication, hearing disturbance, dysphagia. Signs includes the decreased inter-incisor distance, blanching of the oral mucosa, leathery texture of the oral mucosa, shrunken uvula, fibrous bands, inability to move the tongue. There might be vesicles, erosions on the tongue, hyper or depigmentation of the oral mucosa might be seen. Different treatment modalities have been planned for oral submucous fibrosis, which includes physiotherapy, medical line of treatment, and surgical. Physiotherapy includes aggressive mouth opening exercises. Medical line of treatment includes the multiple regimen, which includes multivitamins like vitamin A, vitamin B, foliate injections, and surgical line of treatment includes, it might be fibrotomy along with bilateral coronoidectomy, and it may be various flaps, which includes tongue flap, nasolabial flap. All these treatment plans have their own drawbacks. When coming to the stem cell therapy, the subjects which were included in my study were those subjects diagnosed with grade 1, grade 2, grade 3, and grade 4 OSMF with mouth opening greater than 10 mm, and who have not undergone any previous treatment. And exclusion criteria were the subjects who have a mouth opening lesser than 10 mm and who are immunocompromised and who have difficulty in mouth opening because of other reasons, which includes inflammation, infection, or pericornative, which might be associated with third molar or trauma, or it might be temporomandibular joint disorders. So I had divided the subjects into two groups. The sample size was 20. Group A included the intralesional stem cell therapy and group B included the intralesional drug therapy. In group A, that is the stem cell therapy, I used the centrifugation T-cool method, and the subjects were injected with stem cell for first 15th and 30th day. Whereas in group B, we used the intralesional drugs, which was given on every week, once weekly for 3 weeks. For this suppression of the stem cells, what we did is we withdraw the blood from the most convenient. We from the brachial artery, we withdrew the blood, and I drew about 8 mm of patient's own blood into the cell separator vacuum tube, and that was centrifuged for 6 minutes, but at a rate of 3,400 revolutions per minute. And my centrifugation machine was very specific. It was Remy 8C wing bucket rotor. And after the centrifugation, I got 0.5 to 1 ml of the liquid, that is the stem cells. That was just above the buccal coat layer, that we can tell it as above the gel layer. And the red blood cells settled at the bottom of the
Hello.
Dr. Pooja. I think there is
network issues.
Dr. Aditya, kindly switch other mobiles or other devices because I can hear howling from that side.
Dr. Pooja. Sir, can we move on to the next
Yeah, please
presenter?
move on. Please move on with the next presenter.
Next presenter, Dr. Bhumika CS, UG category. Just please note OMFS UG 01. Dr. Bhumika.
Hello.
Dr. Bhumika, are you ready?
Can you hear me?
Sorry for the inconvenience. Sorry for the inconvenience.
Okay.
Am I audible?
Yeah, you're audible. Sir, should we continue?
Yeah,
Sorry
yeah.
for the
Okay,
inconvenience
okay.
because of network.
Yeah, you please finish off your presentation, Dr. Pooja. Fast.
Yes, sir.
You share the screen and then come back to your
Yes,
slide
sir.
what you presented already fast. And Bhumika, please hold on for some time.
Yes, sir. Yes, sir. Sir, my screen is visible, sir?
Yeah, please continue.
Yes, sir. 2 ml of, as I told, it was treated with the intralesional steroids, which includes the Plecentrix, dexamethasone, hyaluronidase, and lignocaine. And this was the centrifugation machine which I used, and this was in total. And according to the the statistical analysis, the stem cell group had better mouth opening and burning sensation was comparatively reduced. And the burning sensation was measured using visual analog scale. These are the photographs of pre-op, intra-op, and post-op. And I would conclude my presentation by telling that stem cell which I withdrew from the peripheral blood had stem cells, and the subjects had reduced mouth, had reduced burning sensation, and the mouth opening was considerably improved.
Thank you, Dr. Pooja.
Yes, ma'am.
We'll go on to the next presenter. Next presenter, UG category. Just please note Dr. Bhumika CS. OMFS UG 01. OMFS UG 01. Dr. Bhumika, are you ready?
Can you hear me?
Yeah, you're on. Can you please share your screen? Please put it on slideshow.
Can you see the screen?
Yes, yes.
Can I start?
Yeah, you may start now.
Good afternoon, everybody. I'll be talking about oral submucous fibrosis, a review. Introducing to it, it is a debilitating condition of oral cavity which causes abnormal increase production and decrease in collagen degradation. It is a malignant transformation of 7 to 30%, and hence its early diagnosis and management plays a vital role in its management, and a constant efforts have been made for its effective management to reduce it. Introducing it, Shushita in 600 BC described a condition similar to it, and it's called Vidari. There are different other names for it called diffuse oral submucous fibrosis, idiopathic scleroderma of the mouth, idiopathic palatal fibrosis, and sclerosing stomatitis. Talking about epidemiology, in India, it's highly consumed betel nut and areca nut chewing, increase in Gujarat, Chandigarh, Rajasthan, and UP. Its prevalence is 0.2 to 2.3% in males and 1.2 to 4.6 in females. Coming to ethiopathology, areca nut and betel nut, spicy food, nutritional deficiency, and genetic factors. The main culprit in this OSMF is the arecolin, which is present in the areca nut. On hydrolysis, it releases arachidine and it causes fibroblastic stimulation and proliferation, which causes increased collagen synthesis. And the large quantity of tannins that is present in the areca, it causes reduced collagen degradation. So together, increased collagen synthesis and the reduced collagen degradation causes fibrosis leading to OSMF. Classification is based on clinical and histological features by Khanna and Andrade for surgical management of OSMF. Stage 1, it's very early cases. It causes burning sensation of mouth, acute ulceration and recurrent stomatitis, and is not associated with mouth opening limitation. Stage 2 is early cases. Buccal mucosa appears mottled and marble-like. Widespread sheets of fibrosis palpable and inter-incisal distance of 26 to 35 mm. Stage 3 is moderately advanced cases. This causes trismus, reduced inter-incisal distance of 15 to 25, atrophy of vermilion border, buccal mucosa appears pale and firmly attached to underlying tissues, vertical fibrous bands palpable at the soft palate, and pterygomandibular raphe and anterior faucial pillars. Stage 4 is divided into two, A and B, advanced cases. There's severe trismus and reduced inter-incisal distance of 15 mm. And stage 4B is characterized as presence of hyperkeratotic leukoplakia and squamous cell carcinoma. Coming to the management parts, conservative part, physical therapy includes physical exercises and other mouth opening devices and microwave therapy, antioxidants like lycopene, beta carotene, vitamins and mineral supplements, promotion of blood flow, and fibrinolytic therapy including hyaluronidase and collagenase. Medical therapy includes steroids, interferon gamma, placental extracts. Other drugs includes garlic extracts, turmeric, and aloe vera. Coming to the surgical part, extraoral flaps and intraoral flaps. Extraoral flaps include split thickness skin graft, temporalis pedicle flap, nasolabial flap, superficial temporal fascia, and platysmal mucocutaneous muscle flap. Intraoral flaps include tongue flap, palatal flap, and buccal paddle flap, and others including microvascular flaps and allografts. One stage 4 OSMF patient operated by nasolabial surgical flap at our institution, which has inter-incisal distance of less than 5 mm. OSMF release is done initially, and then the flap is harvested from left and the right side, and then the flap is inset. The main advantage of using nasolabial flap is the bulk of the flap that is used for the widespread infected area of the buccal mucosa. On conclusion, it is a potentially malignant disorder, hence the treatment at a very early stage plays a vital role in eliminating the discomfort and to reduce the mortality of oral cancer. Although this disease is studied for many decades, especially in South Asia, it is hardly recognized and it's poorly understood across the globe. Even though the incidence is rising, the people are unaware of the effects of this malignant transformation. So the better integration of medical and dental services may reduce the patient's suffering and improve their quality of life. Thank you.
Thank you, Dr. Bhumika. Just please note that was OMFS UG01. We'll move on to the next presenter. Next presenter, Dr. Sandra Arun. Just please note OMFS UG03. OMFS UG03. Doctor, are you ready?
Yes, I'm ready.
Can you please share your screen?
Sure.
Please put it in slideshow. You may start.
Am I visible?
Yeah.
Yeah. Good afternoon. I'll be doing a review on tissue engineering, a new horizon in dentistry. I believe tissue engineering is the next big thing in dentistry. So what is tissue engineering? Sorry, is my slide moving?
No, your slide is not moving. Your slide is still on the title slide only. Just try it.
Can you please?
It's not moving. Just try sharing again.
Okay, sir.
slideshow.
Okay. So yeah, good afternoon. I'll be doing a review on tissue engineering, a new horizon in the industry. I believe tissue engineering is the next big thing in the industry. So what is tissue engineering? It is an emerging field that applies principles of biology and engineering to develop viable substitutes that can restore tissue defects and function by creating new tissues. For this, we need certain raw materials, which constitute the tissue engineering triad. It consists of the stem cells, like dental pulp stem cells, periodontal ligament stem cells, which migrate into scaffold-like materials, like natural polymer, hydrogel, etc., that support cell growth and proliferation. Along with this, regulatory signals like platelet-derived growth factors, transforming growth factors beta are introduced to induce cell differentiation and tissue formation. Now we'll move on to the various strategies of tissue engineering. The various strategies are cell injection therapy. Here, stem cells are injected into the site of regeneration. Next is the cell induction therapy. Due to the limitations of the cell injection therapy, circulating body cells were recruited and signaling molecules were injected to produce the growth differentiation. The most perfect or the developed form is a cell-seeded scaffold. Cells are isolated, expanded in culture in a scaffold and implanted into the deficient site. Let's look at the engineered orofacial tissues. These are the various engineered orofacial tissues. Moving on from dentine pulp complex, dentine pulp and dentine are regenerated by growth factors, scaffold, and stem cells, or growth factor and scaffold, and can be supplemented by progenital cell induced from residual tissues. Another method is that the periapical tissues can be regenerated by the tissue engineering and the use of external lasers. Now we'll move on to the periodontium. Cell-free approaches aim at achieving endogenous periodontal regeneration with the use of growth factors, well-designed biomaterials, plasma-rich proteins, and associated formulations defects are likely to be restored by endogenously recruited stem cells without an ex vivo cells. Another method is that the stem cells from extraoral site and the intraoral sites are used as a tool for regeneration. Adequate cell density can be reached in vitro, and rapidly available for reimplantation can be reached via a scaffold or free cell sheet engineering. Sometimes the 3D scaffold-based delivery is made used in tissues like constricted bioreactors before transplanting into the patients. Next is the how artificial salivary glands can be constructed. It can be constructed using a biodegradable substratum, material proteins, and salivary graft cells. In another method, we can use the salivary acinar cells cultivated in a 3D gel scaffold, and these cells can secrete proteins and growth factors. We'll move on to the temporomandibular joint. For the regeneration of the fibrocartilage of the temporomandibular joint, it is difficult as the hydrogel, when injected, hydrogel increases the viscosity when cells are incorporated. So flowable hydrogels are injected, and then when it comes in contact with the human body, it has 37 degrees Celsius. It is converted into the gel form. Bioengineered teeth is a complex process, and it is in its initial stages because we have to generate both the soft and the hard tissues. Cells from the epithelial and mesenchymal tissues of prenatal and postnatal tooth germs can be used. Concluding, tissue engineering is a new era, especially in the field where bone and tissue reconstruction is required due to trauma, cancer, etc. The future advances of tissue engineering is very promising. These are the references to my review presentation. That's all. Thank you.
Thank you, Dr. Sandra. Just please note, that was OMFS UG03. I would like to thank Dr. Vinesh Udaykumar sir for his valuable time and inputs. Thank you, sir. Next, I would like to welcome Dr. Alan Abraham sir for judging the next session. He is a reader, Department of OMFS at Pushpari College of Dental Science. We move on to the next presenter. Just please note, Dr. Shivadat Arti. The next presenter, OMFS UG04. Please note, OMFS UG04. Doctor, are you ready?
Yes, ma'am.
Can you please share your screen?
Yes, ma'am. I'm sharing it.
Please put it on slideshow.
Yes, ma'am. Okay, so am I audible, ma'am?
Yeah, you are.
Okay, so with your permission. Good afternoon, respected judges and fellow participants. Today I'll be presenting my paper, Developing and Evaluating an App Based on Android Platform for the Localization of Impacted Maxillary Canines Using Digital Panoramic Radiographs, a retrospective study. So there are certain limitations in conventional imaging systems as we view two-dimensional images of a three-dimensional objects. Even though we view them digitally, there is always a two-dimensional dilemma. And here we are trying to give it a digital solution. The slide is not moving, man.
You may stop sharing it and reshare it.
Okay, man. We are trying to give a digital solution for the same. So over the years, there have been many localization techniques, including the Clark's technique or the Miller's right angle technique, etc. So when it comes to OPGs, Catalyst techniques of 2010 and the Adarsh et al. Technique, which was developed in our college by my professor. The question that arose in my professor's head was, if the panoramic radiographs are being viewed digitally, why can't we track digitally?
Excuse me, Dr. Shivato. I think there is some problem with your audio.
Hello? Am I audible?
Yeah, no, no. Please.
Sorry for the trouble, man. So the question that arose in my, like I was telling before, if the panoramic radiographs are being viewed digitally, why can't we track it digitally? And this was formed the Cuspid Tracker app. So our technique involves, if the ratio formed between the perpendicular lines, as we can see here, the light and the black and the white lines, so the perpendicular lines drawn to the impacted impacted canine and the ipsilateral central incisor from the bicondylar line is more than 1.50, then the canine is found to be located palatally. The other technique that we use in our app is the Cat-Nelson technique. Here, the angulation of the impacted canine to the occlusal plane is being calculated. And if it is greater than 65 degree, it was found that it is 26.6 times more likely to reflect a buccally impacted maxillary canine. In Chaucer's technique, he said that he measured the sizes of central incisors and the canines, and if it was the relationship was greater than 1.15, a palatal displacement was suggested. Here is where my part comes in, the study to assess the accuracy of the app. So my aim was to assess the accuracy of the app, and the objective were to assess the position of the impacted maxillary canines using the Cuspid Tracker app. So we collected the panoramic radiographs, loaded in the app, and predicted the position. And then it was compared with the gold standard, which is clinical pictures and TBCT, and the accuracy was evaluated. So our null hypothesis was the impacted maxillary canines could not be localized using the app. So the study was conducted in our Department of Oral and Maxillofacial Surgery for a period of 3 months. So the sample size was calculated using this formula, and the minimum sample size required was calculated as 76. Our inclusion, the population, our study population consists of subjects belonging to both sexes, aged between 12 and 30 years, requiring surgical exposure and orthodontic correction or surgical removal of the impacted maxillary canine. Wow. Our inclusion criteria included patients more than 12 years of age with unerupted maxillary canine or canine needing orthodontic treatment, and digital OPGs which of acceptable diagnostic quality. And the exclusion criteria was erupted canines and gross distortion of dental arches, as in craniofacial syndromes and canines with existing pathology. Here you can see how our app works with our Adarsh technique. Here we place the ipsilateral canine to the bicondylar line, and we click the play button. And when we click the play button, the value was found to be 1.87, indicating that it was palatal. So statistical analysis was done to calculate its accuracy, specificity, sensitivity, and the likelihood ratios. So here are the results. We can see that 37 out of the palatal, palatal incisors, canine showed that the actual position, and 52 out of the 53 OPGs showed the actual position. So here we can see that the palatal canines show an accuracy rate of 94.8, and that of buccal canines shows an accuracy rate of 98.1, with the total accuracy rate of 96.7. Here we can see the sensitivity, specificity, and other ratios also, which all point towards the success of our app. So these are the areas where our app failed, which is in case of bullseye canines and in case of magnified and rotated canines. So to conclude, we found an easier tool for localization, and our tool, or the Cuspid Tracker app, shows sensitivity towards the buccal canines. So more developments are being included in our app buyers, and which is adding a 3D file viewer and DICOM file converted plugins. That is the digital imaging communications in that is medicine format for plugins, and also adding plugins of difficulty indices for impacted lower molars also. So these were my references and our references. Thank you.
Thank you, Dr. Shivadat.
And I have a question. One second, I have a question. Your presentation was quite interesting. Now, how long did you actually take to develop this app?
So it was almost an year, sir. It was developed by my professor, sir, Dr. Adarsh.
So is it available now online as an Android store, or is it just being still under trial?
Actually, we have not released it yet, sir. It is a
No
working app,
release.
but we have published it, sir.
You only published. Has this been publication? Publication is
Yes,
done?
sir. Yes, publication has been done on NCBI, sir.
Okay. Okay.
Yes, sir.
Okay.
Thank you, sir.
Thank you, Dr.
Any other
Shivadat.
questions, sir? Any other questions from anyone, sir?
Is there any question from anyone? If not, I can move on to the next presenter. Thank you.
Thank you, sir.
Thank you, Dr. Shivadat. Judge, please note, almost UG04. We go on to the next presenter. Next presenter, Dr. Autonomous UG05. Judge, please note, Autonomous UG05. Ready?
Am I audible, ma'am?
Yeah, you're audible. Can you please share your screen?
Yes, ma'am. Ma'am, is it visible?
Yeah, it's visible. You may start.
Good afternoon to one and all present here. Today, I'll be presenting a paper titled Amniotic Membrane for Oral Surgical Defects, a Review. Oral surgical defects not only are prone to infection, but are also prone to scarring by contraction. Through ages, different biological materials have been used to cover these wounds. Today, I'll be highlighting the amniotic membrane that is used to cover these wounds. The amnion is the innermost layer of placenta. It is composed of 3 layers, an epithelial monolayer, a thick basement membrane, and an underlying stroma. It has the following properties. It is a very good stem cell source. It has great growth factors. It is of low cost. It has no ethical issues. It is biocompatible. It has pain relieving effect. It has antifibrotic effect. How is it isolated and preserved? So it is taken freshly and then it is washed for all of its clot. It is preserved as a fresh amniotic membrane, or it is a decellularized amniotic membrane. So it is sterilized using gamma irradiation, para-acetic acid, or by ethanol. So it is preserved as air-dried amniotic membrane, freeze-dried amniotic membrane, freshly preserved amniotic membrane, or cryopreserved amniotic membrane. So the advantages of this is it promotes great epithelialization, it promotes angiogenesis, it reduces fibrosis, it reduces inflammation, it is of low immunogenicity, and it has anti-cancer activity. But the disadvantages and the challenges is it does not have a standardized technique for obtaining it, storing it, and preserving it. There is heterogeneity of human amniotic membrane as well, and it has low mechanical strength. So, applied aspects. By referring to various articles and research papers, hence the literature says that it can be used to close oroantral fistula. So here is a picture which shows a persistent 4 to 6 mm wide oroantral communication. For this, the amniotic membrane was preserved in gentamicin solution and then folded into layers and then sutured close to the fistula. After 14 days, it was seen that the oroantral fistula completely closed and epithelialization was good. So in case of interpositional arthroplasty of temporomandibular joint ankylosis, here both bilateral and unilateral bony TMJ ankylosis was taken into consideration. The amniotic membrane was placed on the condylar heads and sutured to the surrounding tissues. After healing, it was seen that it prevents recurring of the ankylosis, and as well it recovers all the functional movements. In oral surgical defects, after the excision of certain lesions, the wound was closed by the amniotic membrane. The amniotic membrane was sutured on these wounds. So later it was observed that it caused less contractions, it caused less scarring, and then it was easily able to close the wounds. So amniotic membrane in vestibuloplasty, we can see the image of a shallow vestibule. So for this Clark's vestibuloplasty was performed. So on the raw bone itself, amniotic membrane was placed and sutured under LA, and then an acrylic stent was placed over it. So 3 weeks post healing, there was very mild pain for the patient, as well as there was no scarring left, and then epithelialization was good. So we can conclude that amniotic membrane serves as an effective, useful material for immediate coverage of surgical defects with added benefits of its intact epithelial layer. The results showed that the membrane was useful for all patients examined in the study. This method may become an alternative treatment to manage surgical wounds in the oral cavity. These are the references. Thank you.
Thank you, Dr. Anand. Judge, please note that was OMFS UG 05. We'll move on to the next presenter. Next presenter name is not given in the list. Judge, please note, next presenter, Dr. Anushree. Dr. Anushree Fegade.
Yes, ma'am.
OMFS UG 06. Judge, please note, OMFS UG 06. Dr. Anushree. Doctor, are you ready?
Yes, ma'am. Is my screen visible?
Yeah, your screen is visible. Please put it on slideshow.
Is it visible, ma'am?
Yeah, it's visible.
Okay. I would like to narrate one incident. A patient was on the dental chair getting treated by my professor. I noticed the patient suddenly started convulsing violently. It was a seizure. The moment my professor realized, she and other professors swung into action and managed to stabilize the patient without any further complication. And that was the deciding factor for selecting this topic for my research, considering whether the individual dental practices are equipped with emergency kits to handle medical emergencies. Every procedure elicits a stress response characterized by physiological changes accompanied by psychological reaction. The ultimate responsibility of oral healthcare personnel is timely delivery of quality preventive therapeutic services within the bounds of the circumstances presented by the patient. A cross-sectional study was conducted from January to March 2022 among 250 dental interns, BDS and MDS doctors to determine the knowledge and awareness about medical emergency and to assess the availability and applicability of emergency drugs in the dental clinic. In the present study, when inquired if they asked about medical history, including medication and allergy, or obtained field health proforma, then 77.5% of them obtained medical history, while 40.9% of them obtained field health proforma. When asked if they can administer intravenous intramuscular injection or perform CPR, then 46.4% of them were positive. According to the data obtained in my study, 1/3 of the dentists were positive of handling any emergency situation occurring at the dental clinic. The most commonly available drugs were adrenaline, oral glucose, followed by atropine. Least commonly available drugs were hydrocortisone, salbutamol, and glyceryl trinitrate. Management of emergency. It is important that all members of dental office staff should be trained to promptly recognize and efficiently manage any emergency situation occurring at the dental clinic. The unconscious patient should be placed in a supine position with his or her feet elevated slightly so that it increases the blood flow to his cerebral vasculature. If the patient is unconscious, the airway is evaluated. Head tilt and chin lift is performed. In absence of spontaneous respiratory efforts, rescue breathing by mouth-to-mask apparatus, big ball mouth device, and positive pressure oxygen mask is initiated. Mouth-to-mouth ventilation can also be employed. The carotid artery is palpated for no longer than 10 seconds. As soon as the pulse is detected, they can move on to next step in management. However, if no pulse is detected, then it is necessary to call for emergency medical services or initiate chest cardiac compressions. If no breathing and no pulse, then initiate chest cardiac compressions of 30 compressions and 2 rescues. Continue until an ambulance or automated external defibrillator arrives. Definitive care calls for the institution of medical services with administration of drugs and referral to higher center if needed. These are the most common medical emergencies occurring at the dental clinic. Vasovagal syncope can occur in response to stressful triggers such as being on the dental chair. Stress reduction protocols such as good communication, managing anxiety can help to prevent the episodes of syncope. Hypoglycemia is caused due to low blood sugar level characterized by psychosomatic symptoms. Epilepsy is a convulsing disorder of recurrent origin. Respiratory distress can be caused due to inability to maintain blood oxygenation caused by bronchospasm, foreign body obstruction, and status asthmaticus. Chest pain can be caused due to myocardial circulatory insufficiency in predisposed individual. Anaphylactic reactions can occur in response to certain drugs. Hence, it is of paramount importance to ask for the history of drug allergies. Emergency medical kits should be present in every dental clinic to help in the emergencies. Make preparation in advance. You never have trouble if you're prepared for it. The dental practitioner and the staff must be trained to handle any emergency occurring at the clinic. Having medical personnel on call is very useful under such circumstances. However, one should always realize that the best way to manage any emergency is by prevention and preparation. These are my references. Remember, when the disaster strikes, the time to prepare is gone. Thank you.
Thank you, Dr. Nusri. Just please note that was all for COG 06. There was a last presentation in the UG category. We have one more presentation for DG category. She couldn't present yesterday. Dr. Indira Priyadarshini. Just please note Dr. Indira Priyadarshini, OMFS PG 14. Doctor, are you there? Doctor, you are not on. We can't hear you. Hello? Dr. Indira?
Dr. Indira, you are muted. Kindly unmute and then press it. Dr. Indira, can you say hi? No, you're not audible, madam. You're not audible.
Dr. Indira?
You're not audible. You're not audible. What you do, see, you have a mobile with you. If you have a mobile, please log in with your mobile. Put this on mute. Put this laptop on mute. Put the laptop on mute. Okay, now log in with your mobile. Can you hear us? I need a thumbs up if you can hear me. Just raise your fingers, madam. Can you hear me? Just give a thumbs up. if you can hear me. Your audio output is not working. Yeah, fine now. So you log in with your mobile. You do the presentation through the laptop and use the mobile audio to sound your voice.
Okay, sir.
You got it?
Yes,
You
sir.
can, yeah, you can put the video off on the mobile. You can put the video off on the mobile. Do the screen share on the laptop.
Not.
Slide share. Can you see the slide share button down?
Sir, is it visible? Sir, is it visible?
And I just, your audio sometimes working now. No, it's not visible. Please do the screen share.
Sir, is it visible now?
It's visible now. Put on slideshow, please.
Yes, sir.
Slideshow, the third button from there. It's not on slideshow yet. Yeah, click on that.
Good afternoon, everyone. Today I'll be reviewing on osteomyelitis of the jaw. Introduction.
Excuse me, is your laptop mic off? Have you muted your laptop? Because there's too much of echo when you're using two devices. Put your mobile to mute and try this laptop again. Unmute the laptop and see. Is this the last presenter today, Dr. Aditya?
Yes, sir. This is the last presentation from PCDS.
Okay. Yeah.
Sir, am I audible?
You're audible, but too much of echo now. Anyway, you sign out from that mobile. You sign out from the mobile now. Now try to speak. No, you're not audible. You're not audible. There's some problem with your laptop. You have a headset with you. You have a headset with you. There is some error in your side. There's some audio error, madam. We can't hear you. We'll wait for a minute. You try to rectify your problem. If not, we'll have to move on to the next presenter or wind up the session. You're not audible, madam. Unmute and see now. Now you are muted. Unmute. I think it's not possible from your side. Sorry about that. Okay, you can just flip through the slides at least, which will at least entitle you for a certificate of presentation. Flip through the slides, please. Change the slide one after the other. You're on slide number 5, clinical features. Move forwards. Stop sharing and try again. Try sharing the screen. Any more presenters left, Aditya, whether it's PG or UG or delegate category?
Sir, there were 2 more presenters, but they have not yet joined. I think they are not presenting. We tried contacting them also, they didn't pick up their phone.
Okay.
So I think this will be the last present.
Okay. Hello, Indira. Can you see that zoom button? One zoom button will be there on the taskbar down with the zoom logo. Can you see that? On the zoom logo down on your taskbar, you will find a zoom logo. Click right button on that. Can you click right button on that? When you click, you get 2 options, quick zoom and plain zoom. Just click on the plain zoom. Are you seeing? You're not getting that. Are you getting the plain zoom, the taskbar which is open down? The zoom symbol. Okay, one last try with your mobile once more. If that is echoing too much, we'll have to stop, abort the procedure. You put this on mute. You put this on mute. Is your slides moving? Just try. Take the first slide. Go to your first slide. You have stopped sharing also now. Anyway, thank you so much. There's some technical error there. We can't just hold on like that. Okay. See, when you are doing for a hello, you can hear. Okay, so whenever you appear for, I happen to see many of the presenters, not just yourselves. Many of the presenters are not even actually properly prepared for the presentation. You should do it 2 or 3 times before the presentation. Try with your network, form a Zoom link, and try your presentations before you come final for a final presentation. That's not to be seen, unfortunately. Anyway, we patiently waited for your presentation. We tried all your tricks. It's not working. So hard luck. But anyway, we'll provide you certificate of presentation. Okay, when it's come time around. So thank you, Dr. Indira. And now who's the next? If call out the names once more. And if there's no one in the hall, we'll definitely wind up the session. The next participant who's missing, is there anybody in this particular Zoom hall?
Dr. Anupama C. OMFS Delegate 01. Dr. Anupama, are you there?
Anupama.
Okay, then Dr.
Anupama is not there. Then.
Okay, Dr. Mansi, OMFS UG 02. Dr. Mansi.
Spelling, please. Spelling, please.
MANSI.
No, she's not there. Next.
Only that is it.
Okay. Yeah.
Yes.
Dear all, with that, we have come to the end of the paper presentations as far as the oral and maxillofacial surgery scientific paper presentations of the 5th OO National Conference, virtual conference. At this juncture, I would like to thank judges. Now we have Dr. Alan Abraham with us. Thank you, Dr. Alan, for your patient listening and all the efforts that you have put into assess and put marks for these participants. Thank you so much. I also thank Dr. Vinesh. I also would like to thank the coordinators of this session, Dr. Aditya Uday and Dr. Shyamas. Thank you. Thanks a lot. And I also would like to appreciate the efforts put in by the volunteers, Dr. Naveen and Dr. Fayaz, who's been constantly in touch with all the participants yesterday and today, reminding them, calling them multiple times and ensuring that they are appearing in the hall on time so that the presentation goes as scheduled. I really thank all of you once again. And I also thank the judges of IMFS department, Dr. Aglesh Pratap, Dr. Revirajan, Dr. Vinesh, Dr. Allen. And I also thank all others who are supportive in this particular venture. With that, we come to the end of this scientific session, and let us conclude and let us stop this session right now. Is there anything to mention about this, Dr. Aditya? Anything which I missed? Anything? Shyam, anybody? Whom? Is there anything that is missed out? Okay, thank you so much. With that, we can conclude the sessions and your presentations. I request all the participants to be available for the lecture sessions tomorrow, starting at 9 a.m. sharp. We have another 3 interesting lectures from 3 eminent faculties. And thereafter, we'll be having the results declared for the best scientific papers, first, second, and third positions. Okay, so I request all of you to be present online for the lecture sessions as well as for the award declaration and the valedictory functions tomorrow. The link will be provided. It's already provided in the group. So until then, bye-bye. Take care. Bye.